بسم الله الرحمن الرحيم. Good afternoon, everybody. At the beginning, I would like to thank Professor Alia and Professor Tamer for inviting me to such deeply specialized scientific meeting in such a beautiful country which carries many memories for our generations. Thank you very much for the invitation, and it is my pleasure and honor to be here. Going in the same way and same track of lecture of Professor Alia, but looking from another, maybe practical angle. Now, thyroid ablation changing the map of treatment. Does this look pretty? Three-fourths of patients are not satisfied by this such a scar in the front of the neck, so not satisfied cosmetically and psychologically. All the patients, and most of them are females, so this allows and leads the surgeon to search around to find another way to avoid such surgical scar in many ways, as you see. Now, let us leave no scar at all. Being an interventional radiologist with background and experience in thermal ablation along the last maybe 23 years in the liver, lung, kidney, and bone also, now thyroid ablation. Thyroid ablation is a non-surgical, minimally invasive technique that effectively treats functioning and non-functioning benign nodule. Why thyroid ablation? First, it preserves the thyroid function. Better cosmetic outcome with no surgical scar, daycare procedure with no hospital stay, safe with minimal complication rate, no risk of general anesthesia, and of course, it is suitable for patients not fit for surgery. Actually, this is not a novel technique, as Professor Alia touches. First studies come from Korea at 2008, and then at 2009, first Korean recommendation, 2012, the Korean recommendation update, 2015, the first Italian opinion statement, 2016 comes in the American guidelines, and in the same year, the England guidelines in ICE, including the thermal ablation. Then 2017, there is update of another update of Korean recommendation. 2018, it is FDA approved. And 2019, it's included in the Italian minimal invasive thyroid therapy guidelines. 2019, the Austrian got clinical practice recommendation. 2020, European Thyroid Association clinical practice outline. And this year, 2022, international MDT consensus. So what's our agenda to touch this relatively novel technique? How does it work? For which patient? How do we assess and to prepare our patient? How do we do it? What are the outcomes? And the actual cases done and followed up. How does it work? Actually, we have main two modalities of thermal ablation, settled two modalities of thermal ablation. First and the oldest one, the radio frequency, and the second one is the microwave. This is the setting of radio frequency, as Professor Alia said. We have this closed circuit. في pointer؟ أنا آسف معلش. ما بيشتغلش على السكرين مش كده؟ We creating this closed circuit generator for radio frequency wave connected to this grounding pads, and the radio frequency generator is connected on the other side to the electrode, or we call it the needle, which goes inside the patient. So look for this closed circuit. The radio frequency generator produces high frequency alternating electric current oscillating between 200 and 1200 kilohertz. This current, when goes to the electrode, goes inside the tissue, it produces what's called ionic agitation. Ionic agitation will produce what's called frictional heat. The temperature increased inside the nodule to about 60 to 100 degrees centigrade. And this creates coagulative necrosis in few millimeters around the electrode. Not only that, there is another mechanism called the conduction heat. There is slower additional thermal damage to the target tissue and the tissue further from the electrode. But in ablation of the thyroid nodule, we depend on this mechanism. We ablate the millimeters around the nodule because the ablation in the thyroid must be a controlled one. We ablate by a technique called moving shot, as we will explain. So it must be controlled, as the space in the neck is very, very small, and the surrounding structure are very precious. And this also, the newer generation of thermal ablation, the microwave. The microwave involves generation of high frequency electromagnetic field, also produce oscillation of polarized ions, specifically the water. It acts on the water molecule. It causes friction and heat, and at the end, also coagulative necrosis. Actually, microwave is a more aggressive type of ablation. For which patient we do this ablation? Of course, as Professor Alia said, for benign nodule. Which benign nodule? Going through the famous this classification, pathological and cytological classification, we produce, we do the ablation for the Bethesda 2 patient, which are histologically proved via FNA in 55 and 74%. What is the size? The size, similar size, produce different symptoms in many patients. So it is very difficult to do an objective size criteria. So we depend on the clinical indication, which are the cosmetic figurement and the compression symptoms of the surrounding structure, esophagus, trachea, etc. And these are two main indications, cosmetic and compression, C and C. Functioning thyroid nodule, RFA is an added option to surgery or radioactive iodine in treating autonomous functioning nodule with success rate up to 75%. And because the efficacy is associated with nodule volume reduction of 80% or more, so RFA is suited well for nodules less than 3 centimeter, functioning nodule less than 3 centimeter, and when the surgery and the radioactive iodine are contraindicated, and of course, we must make sure that the hyperfunction is due to the functioning nodule, not due to toxic multinodular goiter or grave disease, by doing routine scintigraphy for the patient. Bethesda 3, ablation is not recommended, as it is neither completely remove the nodule, nor does it facilitate a definitive diagnosis as opposed to surgery. And then, how do we assess the patient before the procedure? First and the most important, the ultrasound planning. We examine the patient by ultrasound to define the size. And actually, we make a baseline volume for the nodule for the following follow-up, measure the depths and the 3 dimensions, and calculate the volume and make it as a baseline for the consequent follow-up, and see how many nodules, the composition of the nodule, solid, cystic, or mixed. We call it spongiform, and by the way, the spongiform nodule, from our experience, are the most responsive one for the radiofrequency ablation. And when you put color on the nodule to assess the intranodular and the perinodular vascularity, and this show how the ultrasound appearance of the different nodules may be solid with some cystic component, mainly cystic with solid component, and this heterogeneous one, and so on. Nodule location is very important, as we said, because the thyroid gland is surrounded by many precious structures. Look here, this is the thyroid, this is the jugular vein, and this is the vagus nerve, this is the carotid artery, this is the recurrent laryngeal nerve right, recurrent laryngeal nerve left, the esophagus, and the other side. So, as Professor Alia said, we have here this triangle, we must avoid it. We call it dangerous triangle. We do, as we will see, the treatment through transismic approach by moving shot technique, sparing this area of dangerous triangle. And if we look after the ablation in this area, the hypoechoic or black one, the ablated area, and we preserve here this dangerous triangle to be away from the recurrent laryngeal nerve. Sometimes this another variant from recurrent laryngeal nerve here, so avoid these valuable structures. We have such a classification when we look to the location of the nodule to determine the risk of ablation. If you have a nodule like this, away from the edge by more than 2 millimeters, away from the carotid sheath and away from the trachea and the esophagus by 2 millimeters in the middle of the thyroid tissue, this is low risk. If it is near or adherent to the carotid sheath, it is medium risk. If it is here adherent to the trachea or the esophagus, so it will be high risk. But if it is both like this, adherent to both structure from both sides, it is very high risk. Also, we must do the fine needle aspiration and, of course, preoperative laboratory tests, which are thyroid function tests, CBC, and the coagulation profile. As Professor Alia said, this is the regimen of stopping the anticoagulation, anticoagulant, antiplatelets as aspirin must be stopped 7 or 10 days before the procedure, warfarin 5 days, and the new direct anticoagulant 24 to 36. And all agents can be safely resumed 24 hours after the procedure. And look for this. We can assess the vocal cords before the procedure, during the procedure, and after the procedure by ourselves, by what we call it sonographic laryngoscopy. Look for this beautiful video. If you put the ultrasound on the larynx here, look, the vocal cords are freely moved. This is the right one, left one, and the airway in between. We assess the mobility of the vocal cords by the sonographic ultrasound before the procedure, and maybe during the procedure and after the procedure. Also, informed consent is important, and the most important and the more important more important than the consent itself, to speak with the patient about the procedure, what is the expectation, what is the outcome, what is the concept, the risk, and the complication, explain in very clear way before the procedure. And how does we do it intra-procedurally? At first, we start about what is called local anesthesia or hydrodissection. Xylocaine diluted with saline, and we inject this fluid to produce what's called the hydrodissection. Then we start to ablate by what's called moving shot technique. We go through transismic approach. You go from the isthmus, then very deep to the tissue of the nodule and start to ablate area by area superficially, ablating this plan, going to a lateral one to finish and cover all the volume of the nodule, of course sparing the dangerous triangle or dangerous area of recurrent laryngeal nerve. And look for this actual cases, follow the steps of the procedure. This is a small bit of xylocaine before the hydrodissection here. This is a sonographic picture. After that, we go by this needle for hydrodissection, trying to find a plan. We inject this hydrodissection fluid immediately superficial to the capsule. We find the plan here. Go in the plan, inject more and more to surround the nodule and separate it from the precious surrounding structure of the carotid sheath and the recurrent laryngeal nerve. And look for, we concentrate on the size of the needle. It's about 18 gauge needle. Look for this beautiful hydrodissection which separate the carotid sheath and maybe recurrent laryngeal nerve here. And we start to put the needle to go by the needle from this isthmus here, sparing the dangerous triangle deep in the tissue. And when you are in a good position, switch on the radio frequency generator. The ablated area looks echogenic like this, and go superficial to the capsule, and go to another neighboring plan, lateral, another plan to cover all the nodule by ablation. When you're doing the procedure, we must have what's called the three-dimensional imagination, because this is two-dimensional. You have third dimension, the cranial and the caudal dimension. You must cover all the tissue of the nodule. Look here, this is our scar for the operation, which is covered by this small area of plaster. This is an added technique which comes by more experience. When the nodule have this perinodular vascularity, this is the artery. We go by the needle to ablate it. We call it afferent thyroid artery ablation. We ablate the artery, we transfix it, ablate deep to it, and drag superficially to ablate all the artery going inside the nodule. When you ablate the artery supplying the nodule, like you're doing an embolization. This will add to the regression rate of the size of the nodule and increasing the efficiency of the thyroid ablation, especially in the large nodules. What is the post-procedure care? Ice pack, very important immediately after the procedure to increase edema, and the ultrasound to assess the larynx and the voice, observation maybe 1 or 2 hours after the procedure, and give the patient some instruction. If you have one of this severe pain, voice changes, color changes, shortness of breath, we must tell us. And of course, this is our routine post-procedure treatment: prophylactic antibiotic, simple analgesic, paracetamol, and the anti-edematous drug. And what is the outcome for the procedure? Before the outcome, this is the protocol, the standard protocol for follow-up. We follow the patient 1 month, 3 months, 6 months, and 12 months after the procedure by 3 methods. Number 1, photographic assessment. We take a photo for the patient before and after the procedure, 1 month, 3 months, 6 months, and 1 year. And we have the baseline volume. And every time we calculate the volume and see the % of reduction rate. And we check also the thyroid function tests. And at 12 months, the near maximum expected thyroid reduction had typically achieved. Long-term follow-up, as Professor Alia said, is mandatory. We found that 5 to 24% of the nodules regrow after 3 to 5 years, which may need another session or surgery. And of course, as Professor Alia said, this depends on the remnant of the nodule and satisfaction or symptoms of the patient. radiofrequency appear most effective ultrasound ablation technique for treating solid mixed spongiform non-functioning nodule. This is from the literature. The reduction rate, 64% at 6 months, 76 at 12 months, and 92 at 3. And when comparing it to surgery, of course, radiofrequency has few complications, better health-related quality of life, and improved or preserved thyroid function. And this is our experience. We published a first paper 2 years ago at 2021, including about 100 patients for thyroid ablation. And these are our results, relatively comparable to the international results from literature. 58.4% at 1 month reduction rate, 73.2 at 3 months reduction rate, 82.5% at 2 months. And of course, this is accompanied with significant improvement of compression symptoms and cosmetic problems for the patient. 10% of our patients need second session, and these 10%, most of them was huge nodule with retrosternal extension. When we have such size of the nodule, we do ablation as much as we can, and when the nodule regress, the intrathoracic component will be dragged up in the neck, and in the second session we go targeted to the remnant thyroid tissue in the neck. Again, the complication from the literature is about 2.38%, the overall complication, 1.35 major complication. The major complication includes voice changes, and it is 1.44%, mostly transient and recover within 2 to 3 months, and nodular rupture in 0.117%, mostly recover within 2 to 3 months. And we have some minor complication like pain, which is managed by simple analgesic. And actually, nowadays, because we have the sonographic laryngoscopy, we do the hydrodissection or local anesthesia accompanied by light sedation, because most of the patient had an anxiety. And this also decreased the pain during and after the procedure. Sometimes you get small hematoma resolve in 1 or 2 weeks, skin burn, vomiting, and minor complications. This is our results in our study. 97% was no complication, but 1% was voice changes, transient, hematoma, skin burn, which are recovered 100%. Coming to the last part of our talk, actual cases from with different size and shape of the nodules. This 21-year-old female, which have a cosmetic complaint, euthyroid status, the ultrasound so right, thyroid lobe complex nodule or spongiform nodule, fine needle aspiration, of course, showing Bethesda 2 nodule. This is the shape of the nodule, it's spongiform. It's about 29, and this one, bulging superficially. This is pre-procedure, 3 months follow-up, and 1 year follow-up. And if you look the ultrasound picture, this is before. This is the volume, 29, 3 months, 32, and 1 year, 1.7 cc. Another patient, 43 years old female with recurrent goiter after the operation. It has huge mass causing left vocal cords compression with subsequent difficulty of general anesthesia, euthyroid, recurrent left lobe thyroid nodule, mostly cystic with a solid component, Bethesda 2, and this the appearance, the nodule volume is about 100 cc. Look here for the scar of the operation and this huge nodule. We aspirate at first the cystic component, then we started to ablate the solid component, and this is a follow-up. This is pre, and this is 1 month immediate follow-up. This is pre 100 cc almost, and after 1 month is markedly regressed after the aspiration and the ablation to about 4 cc. Again, 55 years old female with cosmetic complaint, euthyroid. The ultrasound shows 2 nodules, one in the isthmus, superficial, and the other one in the left lobe, besides the 2. This is the isthmic nodule, 1 cc, and this is the left lobe nodule, about 2.3 cc. We do ablation, but after the first week, we have this erythema and the inflammation. In many days, we have this discharge. We give it intensive antibiotic, follow her up, and this is after 1 week, the inflammation subsided and improved. And this is a picture after 1 month of the treatment. This is the pre, 1 cc, the isthmic nodule. 1 month became 0.7 cc, and the left lobe 1, 2.3 cc, became after 1 month 0.6 cc. Another patient, 80 years old male, compression of left carotid artery with fainting attack. The ultrasound showing large left lobe thyroid nodule, FNA, of course, this is the 2, and rejected from surgery due to risk of anesthesia. This patient from Alexandria, by the way. And we have this huge nodule which causes fainting attack for the patient and the postural complaint. This huge 247 cc. This is pre, 1 month after, and look after 3 months. This is pre-ablation. After 1 month, the volume markedly regressed to 118, and at 3 months, it became almost 96 cc. Another type of patients complaining of neck bulge, 36 years old male, neck bulge, ultrasound showed isthmic cystic nodule encroaching on the right nodule. This is the 2, and this is a picture. This is a nodule here. This is superficial, this is the trachea, and this is the skin. And this is pre-ablation, 1 month after ablation, and this is 1 year after ablation. Look the difference. And this is pre-ablation, 5.7 cc, 1 month 2.2 cc, and at 1 year 0.6 cc. Again, pre-ablation 1 year after, 85 cc after 1 year, 7.3 cc. And the last patient, she was a doctor having an anxiety and palpitation. She closes her clinic for many months. Hyperfunctioning thyroid nodule, and when we doing scintigraphy, we found this nodule here. And after ablation, this is a photographic picture before, and this is after ablation. And if you look for the TSH, there is marked elevation of TSH after the procedure, meaning complete control of the nodule, which was a small one. So, ultrasound-guided ablation procedure is an effective first-line alternative to surgery for patients with benign thyroid nodules leading to compression and/or cosmetic symptoms. Thermal ablation procedure can be a safe therapeutic alternative in patients with autonomous functioning nodule, and contraindicated maybe for surgery or radioactive iodine. RFA has a very low complication rate, most of which are managed conservatively, in addition to having multiple advantages over surgical management. And thank you very much.